The first step in repairing a perineal laceration is determining the degree of the tear. A first-degree tear is superficial, involving only mucosa and perineal skin. A second-degree tear, which we'll be focusing on today, involves and extends into the bulbospongiosus and transverse perineal muscles. Third degree extends into the anal sphincter, and a fourth degree extends through the rectal mucosa. This model here depicts a second-degree laceration. You can see the extension of the tear into the perineal muscles. You can see the base of the vaginal introitus, the hymenal ring, and the interior aspect of the laceration, which is internal to the vagina. In this video, we will be demonstrating a second-degree repair specifically. Palpation and visualization here do not reveal damage to the anal sphincter complex. It additionally can be helpful to approximate the edges of the laceration before beginning the repair, as you can visualize how the edges should come together. For tools, you'll need a needle driver, pickups, scissors, laparotomy sponges for blotting, and suture. We standardly use an absorbable 3/0, usually on a tapered needle without cutting edges, called a CT. Vicryl is a common choice for suture material. You will administer lidocaine prior to starting the repair, standardly entering at the vaginal introitus and administering lidocaine along the inner edge of the laceration and the perineal external edge of the laceration. You will repeat this process on the other side of the tear. You will start by placing a suture 1 centimeter above the vaginal apex of the laceration. This stitch is important for hemostasis, so it's important to take a deep bite, and when you tie down, to tie the knot down tightly. You will tie this with a surgeon's knot and then complete 4 total throws to secure. Next, you will proceed with a running stitch to close the vaginal mucosa and the underlying fascia. This can be locking or non-locking, depending on your need for hemostasis. Most providers lock these stitches to the level of the hymenal ring. This is what we're demonstrating here. One thing many providers struggle with when learning this is it can be tricky to locate your needle in the deep tissue. There are a few strategies to help with this. You'll see some of them on the next stitch here, where, as you can see, the tip doesn't quite come through, and so the provider will move the needle driver further back along the needle to be able to push farther through. Also, you can use the forceps as a counter pressure to leave space in the tissue for the needle tip to be revealed. Once the hymenal ring is reached, you will then change planes. As you'll see here, you'll enter the vaginal mucosa near the previous stitch, and then you will exit in the perineal plane. Do not lock this stitch, otherwise it will become tangled. Prior to throwing the next stitch, you will use a gloved finger to palpate the defect. By palpating, the provider determines the depth of the defect and how deep the next stitches will need to be placed in order to close the area. You will start at the anterior or superior aspect of the laceration, the area closer to the vagina, and throw a non-locking stitch from right to left in the horizontal plane. Note here how the provider holds the needle driver in the horizontal plane in order to achieve this angle. Pull that stitch tight, and then you will palpate the defect again. You will continue progressing downward towards the bottom of the laceration, staying in that horizontal plane. It is important not to incorporate the anal sphincter into the stitch, which is one of the reasons staying in that horizontal plane is so important, because the anal sphincter lies posterior to where you're currently working. If, for some reason, you're unable to close this deep area, there is the option to place a separate interrupted stitch at any time to close the extra tissue. Now that that area is closed, we will move towards the subcutaneous closure. To do this, you'll have to change planes again. So you see you'll enter here within the laceration and then exit directly at the perineal apex. Again, as with every time you change planes, this will be a non-locking stitch. Now that you've successfully changed planes again, we will proceed to do a running subcutaneous closure, staying parallel to the contour of the skin. As you'll see, the needle enters just subcutaneously, stays in that plane, and exits at the same level. For the next stitch, you'll load the needle backhand and enter the tissue exactly opposite where you exited the last stitch. If needed, you can hold the string across to show exactly where that level is. You'll continue that up until you reach the vaginal mucosa. Next, we will enter the vaginal mucosa opposite from where the last stitch was exited, and then exit internal to the hymenal ring. It can be helpful to use a backhand technique for this stitch. Ensure that you're not applying too much tension here, as it can cut off blood supply and impede healing. The last stitch will be one more bite in the vaginal mucosa deep to the hymenal ring, and then you will complete a knot with the remaining loop here. Again, being careful not to apply too much tension. Finally, you will visually inspect and palpate the closure to ensure that hemostasis and reapproximation is achieved.